Yeah.
So, greetings and a warm welcome to all the dignitaries present here. I'm Anushka from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarnet serves as the digital partner for this event, hosted by the Indian Menopause Society, Hyderabad, and the focus of today's session is Overheater classes. Topic is postmenopausal bleeding from panic to plan. So let's begin today's session, for which I would like to invite Dr. Payal to take over.
Good evening, everyone, and a very warm welcome to today's session. Our speaker today is a very dear friend. She's amazing, a good teacher, and a very, very humble person. So I request Dr. Sandhya to introduce our speaker today and start the session.
Thank you, Payal. Thank you, Anushka. It's a real pleasure to be associated with this Yohita program. Yohita, Know Your Mother. This is the brainchild of Dr. Ambuja Madam. When she was the president of IMS, she wanted the concept of menopause and the mothers, what they're going through across the country. And she has started this program that Know Your Mother, so that at least the family members will know the plight or the midlife troubles of the mother and the elderly ladies in the family, so that the word will spread. So that is how this concept was born, and it has taken such great extensions. And today, with Dr. Revathy in charge of Yohita program, Yohita Know Your Mother, this teaching program of Hyderabad Menopause Society, it has become a very famous online teaching class where all HMS members are awaiting to listen to. Dr. Revathy, today's speaker, is a consultant gynecologist and obstetrician at Apollo Hospital, and she's a very famous endoscopist, hysteroscopist, laparoscopist, and she's well versed in her job. And by making Dr. Revathy as the in charge of this teaching program, HMS takes pride that it is going on so well, all because of her. Thank you, Dr. Revathy. And shall we go ahead and start the classes, please?
At the outset, my sincere and deep gratitude to the HMS family, Sandhya ma'am, and my other seniors who are perhaps here, but then a special mention to Ambuja ma'am, Tripura ma'am, Dr. Meeta, Dr. Payal. First, kind words, thank you very much. Second, gratitude for giving me an opportunity to share something which is very close to my heart. And today's topic is something which is very close to my heart. Let me begin my screen sharing. Yeah, so I share the entire screen. So, where am I? It is not stop share. Yeah. How do I go? Yeah, I'll open this first. This is the one, yes. Then I go to a slideshow. Yeah. Yes. So how do I go to Zoom? Open Zoom. Yeah. Share. Then share. Yeah. No. Okay. Share. All right. You see, these technical glitches still make me like a baby, trying to kaun sa click karna hai, kya click karna hai. So no, this is a topic which is very close to my heart, and this is something which I have been following for many years. And I thank HMS for giving me an opportunity to bring my thoughts into view in front of my respected seniors and my dear colleagues. I see my classmates from Bellary. Thank you very much for attending. And all the dear gyneks who have spared time on such an auspicious day of Varalakshmi Vratam. So it is something totally gynec, is it not? Because most of our topics are, into orthopedics, into medicine, or into psychiatry, and we are still learning. But this is totally our topic. It is something which we practice every day but there are protocols that are strictly laid out how to handle a postmenopausal bleeding. And operative hysteroscopy is one thing which has helped us to change the way we can give alternatives in a case of postmenopausal bleeding. It is true that 90% of, can I reduce this further? Minimize. Okay. It is true that 90% of endometrial cancers, they present as postmenopausal bleeding. It is also true that only 10% of them are actually cancers. So in between, we have an 80% figure of perhaps benign. But still, in a younger age group and in an older age group, see, in a much older age group, the postmenopausal bleeding is most likely or more likely to be an endometrial malignancy. So the Western standard, wherein the average age of menopause is about 50-51, you start labeling a person as postmenopausal bleeding after 12 months of amenorrhea. In the Indian standard, wherein the average age of menopause is 46, we label a woman postmenopausal bleeding if she has finished 6 months of amenorrhea, and we need to start our investigations. Now, what are the causes? Benign, malignant, premalignant, and non-gynecological and systemic. Benign is very common. We all know atrophic vaginitis, atrophic endometritis, lots and more of polyps, endometritis, genital trauma, intra-space occupying lesions inside the uterus. These are all large causes of benign postmenopausal bleeding. What are the malignant and premalignant conditions? In the premalignancy, it is endometrial hyperplasia with or without atypia. In malignancy, primarily endometrial cancer could mean any genital cancer, including cancer ovaries. All of them can present as postmenopausal bleeding. What are the systemic causes? See, if anybody is on HRT, which could be very common, today you are more likely to find somebody using HRT, tamoxifen, people on anticoagulants, people using herbal supplements, and there could be bladder sources and bowel sources also for the postmenopausal bleeding. So what do you do? Now you have got a patient who has come to you in the OPD with postmenopausal bleeding. Try to stratify her risk first. Find out if there is a genetic history. Is she on tamoxifen? Is she obese with a high BMI of 30? This automatically goes into high risk category. Is she having diabetes? Is she PCO? Is she nullipara? So this comes under high risk. So when you put a patient into high risk, that means automatically we may have to directly go for a tissue sampling rather than do anything before that. Okay, now the patient has come to us. We are going for the history, which is our first encounter. बहुत प्यार से हम history लेते हैं. So what are we going to find out? We find out the nature of bleeding, her hormonal axis, pharmacological drivers, any other systemic context. So categorize the nature of bleeding first. Is it the first episode? Is it a persistent or recurrent episode? This, again, we need to be careful. Is she having a widened estrogen window? Did she have an early menarche and a late menopause? Is she nulliparous? Has she had perimenopausal DUB? Has she had a history of endometrial hyperplasia? All these come under the widened estrogen window and a higher risk. Now find out if she is on any kind of a medication like either estrogen therapy or MHT-HRT, or is she using any anticoagulants. Then you find out the overlapping systemic risk. Is she having diabetes, hypertension, family history? So this puts her under a very high risk of malignant pathology. So now you have finished the history. Now you start examining her. You do a systemic risk stratification. So how do you do that? Some of them very rarely come with hemodynamic instability and severe bleeding. So that, of course, is a red flag. You need to take care of it. But otherwise, assess the obesity because it's a primary driver of peripheral estrogen conversion and a major risk factor for endometrial cancer. Palpate her abdomen, and I will also say palpate her breast because this is an opportune time where a woman has come to us and we shouldn't let her go without a breast evaluation also. Why are we so worried about obesity? When there is obesity, there is an aromatase hyperactivity. This aromatase hyperactivity converts androgens to estrogen. So, there is a chronic state of unopposed estrogen in the body, and this results in persistent cellular proliferation, endometrial hyperplasia, and bleeding. That is why obesity carries a 2 to 5x relative risk for a type 1 endometrial cancer. Then we have done the systemic examination. Now we come to the pelvic examination, which is very mandatory. What do? We do a per speculum. You look for any atrophy. You look for any trauma, ulcerations, erosions. You look for any cervical lesions like a polyp or a growth or anything there. Look for any discharge or vaginitis. So this is a big examination that you will do. This is a patient with a foreign body which was left, some pessary which has been left inside her for 25 years, which was causing bleeding, which was removed. Do a bimanual examination and do a rectovaginal examination. Do a bimanual examination, mobility of the uterus, look for any masses, adnexa. You look at if there is any bleeding hemorrhoids, you look for any nodules in the rectovaginal pouch. So any other non-gynecological, any gastrointestinal causes for bleeding, we need to look at everything. Now, every postmenopausal woman who comes to us, we are going to do a menopausal workup, which includes routine investigations, CBC, urine routine, LFT, RFT, lipid profile, ultrasound abdomen, a pap smear, in addition to mammography, bone DEXAs, look into stool for occult blood too. So once we have got into the systemic workup, then which is the most important diagnostic modality, which has changed the way in which we look into postmenopausal bleeding. So it is the transvaginal ultrasound, in which you evaluate the structure of the uterus, ovaries, you look for focal pathology along with the endometrial thickness. So this is the simplest non-invasive outpatient procedure which we would do for every woman, and there is absolutely no doubt about it. What is required? You must identify the entire endometrial line, and you must be able to see the anteroposterior diameter. And what you look for is a thin, distinct, uniform endometrial echo in its entirety. Sometimes you may have an axial uterus, which is otherwise called as a mid-post uterus, obesity, adenomyosis, in which we may not get this entire picture, and we must document that we have not seen it in its entirety. So the endometrial thickness of less than 4 millimeters, which is measured in its anteroposterior diameter, excluding the endometrial fluid. If it is less than 4 millimeters, it is a reassuring endometrium, and it is more than 99% negative predictive value for cancer. So this is an expectant management. If it is more than 4 millimeter, it is an actionable endometrium. That means we can have a higher risk of cancer, and we need to proceed with sampling. So once more, the reassuring threshold is less than 4 millimeter. The action threshold is more than 4 millimeter. This could mean anything. It could mean polyps, inhomogeneity, could mean malignancy. And so it warrants immediate tissue diagnosis. Now again, an ACOG recommended mark is 4 millimeters. But there are some who say 3 millimeters. Now 3 millimeters is very highly sensitive but very low specificity. It can lead to over testing. So 4 millimeter is definitely safe. Now, what if you have a patient who comes to you with no symptoms, but she has an endometrial thickness of 6 or 8 or 9? What do you do about it? So the protocol says that in an asymptomatic woman, you don't start a tissue diagnosis or an investigation until it exceeds 11 millimeters. Tissue diagnosis only more than 11 millimeters in an asymptomatic postmenopausal woman. Now, sometimes the ultrasound is not enough. We need to bypass the ultrasound. What are those situations? One is in a woman who is on tamoxifen for perhaps CA breast. So what does tamoxifen do is it causes a subepithelial stromal hypertrophy. And so endometrial thickness is not a measurement which can be of use. So in a patient with tamoxifen user with postmenopausal bleeding, please directly go for a biopsy. What about a woman who has recurrent postmenopausal bleeding? You have done an ultrasound before, it is very negative, her bleeding has stopped and you have sent her, but she has come back with recurrent postmenopausal bleeding. Again, don't rely on the transvaginal ultrasound and go for a directed biopsy. Now, there is an entity called as type 2 endometrial cancer. These cancers are estrogen independent. So they come in atrophic and thinned endometrium. They are high grade and they have a higher likelihood of invading the myometrium and spreading to lymph nodes. These are associated with P53 genetic mutations, HER2/neu overexpressions. In these patients, you may have a normal endometrium. You may have an atrophic endometrium of less than 3 millimeters. But what is normally seen is a persistent bleed. And these patients with a less than 3 millimeters with bleeding, we need to go for a tissue diagnosis regardless of the endometrial thickness on ultrasound. So now coming back to the master algorithm, okay, she is a postmenopausal bleeding diagnosed. We have done a clinical examination and we have ruled out all the non-endometrial causes. You have done a transvaginal ultrasound, you get a less than 4 millimeter echo, reassure. Tell her, don't worry, there is nothing. But what if you get a more than 4 millimeter or the echo is not clear? You have to proceed with a tissue diagnosis. What if you had sent her earlier and she comes with persistent bleeding? You have to proceed with a tissue diagnosis. Now there is one concept called as loss to follow-up. So there is a woman who comes to you, you have said everything is normal, ticket, don't worry, you're not having bleeding, come back if you bleed. What if this lady goes away? She never comes back. She's saying, doctor has told me I'm okay. So there is a concept called you close this loophole. That is, when she comes to you, do a TVUS, just do an endometrial sampling in the initial visit. Endometrial sampling could be either by PPL or by office hysteroscopy, which I will speak about later. So this is a very safe way of handling these loss to follow-up loopholes, and you may not miss these type 2 cancers also. Now let us talk to the next step. We are going to go and do a tissue sampling. So what are the various ways in which we do a tissue sampling? The blind technique. The blind technique of the outpatient we all use is called as a PIPL endosampler. There is a limitation. It can only take a small portion, that is less than 4% of the surface area. High failure rate, you can miss focal pathologies, and sometimes it fails because of cervical stenosis. We are talking of only postmenopausal bleeding in today's lecture. Now let us combine the other blind procedure, blind DNC. You have a blind people, you have a blind DNC. A blind DNC, you give anesthesia. There are some anesthesia risk, but even that is poor, less than 50%. Many times you get an insufficient sample with a DNC. So when you compare these two, a PIPL is considered superior because of safety, convenience, and resource utilization. Blind DNC is no more superior to a PIPL. Now, what is the beyond the blind sampling? Direct visualization is a vaginoscopic hysteroscopy, which is considered as the gold standard, and this can be done in the outpatient setting. So isolated DNC is outdated. It should no longer be used as a first-line method for investigating postmenopausal bleeding. So now let me take you to one of my patients for whom we have done an office hysteroscopy. So we have negotiated the internal loss. This is the inside of the cavity wherein you find, you see all these are additions. Endometrium is not looking very bad. Okay, but there is, you see this focal area of hyperplasia, which you need to sample. So now this is not possible in a blind procedure, and a hysteroscopy gives a targeted viewing. It is very accurate because you can just biopsy that particular area. You can remove lesions. Strongly recommended for endometrial thickness of more than 4 millimeter or any focal findings. So this again is a patient who has come with postmenopausal bleeding. We have done an office. A vaginoscopic technique is when you don't use anything to touch her cervix, and it is the most painless way of performing a DNC. The challenges are mainly negotiating the external loss and the internal loss. Now what do you see? The rest of it is reassuring. There is a tiny polyp here. You see that this polyp can easily be removed in the office setup with a scissor. So when do you actually do a DNC? DNC, yes. What is the indication for a DNC? You have done a hysteroscopy. The entire endometrium is bulky. Then you do a curettage to remove the diffuse disease. In a patient with acute emergency, which is very rare in a postmenopausal bleeding with thick endometrium, but in that case, you could, curate the endometrium and see that she stops bleeding. There are some areas where there is a severe resource limitation, which could be anywhere in the city, because it's not everybody who buys a hysteroscope and gives it to us. Not only hysteroscope, they need to get us a resectoscope, a hysteromat, which is a pretty costly package. So when people fails, Hysteroscopy is completely unavailable. Then you can do a DNC. Now, what if you get an insufficient sample? Many times, so you've done a PIPL, you've done a DNC, you don't get a sample because it's an atrophic endometrium. Do you say that it is okay? Never. It is not reassuring. See, if the bleeding is persistent, you have to go for a hysteroscopy and a directed biopsy because there could be a focal malignancy. Now, this is a lady who came to us with a persistently thickened endometrium over the last 2 or 3 years. She says there are cystic spaces, 22 millimeters endometrium was the. So I normally expect a polyp in such patients. But see, the atrophic internal loss, we have negotiated it. You can see all that mucus coming out. And what do we find? We find a submucous fibroid. Look at the endometrium. It's atrophic. Seeing her itself, I know that this is nothing to worry about. But then I do proceed and remove the fibroid because I tell her there's nothing to worry. I take a biopsy of the fibroid, it's benign, but her endometrium will continue to be thick. And the next doctor might just say that perhaps your endometrium is still thick and it is safer to remove it. So I've removed that fibroid. Removing a fibroid is a little more riskier procedure than a polypectomy. Now you see this patient. She's again a office hysteroscopy. Look at the vascularity. You look at this vascularity. It is not following hierarchy. First Sandhya ma'am, then Lakshmi Ratna ma'am, then Payal Bhargava, then Madhavi. No hierarchy. It is behaving the way it wants to. Comma-shaped vessels. Large vessels, which are not following a pattern. This is a CA endometrium, which you can just see and make out. Okay, now we have talked about hysteroscopy. Now let us talk about the simplest reason for postmenopausal bleeding, and that is atrophy. So what happens? Why do you get this atrophy? There is an estrogen deprivation. And what does it do? There is a matrix metalloproteinase enzyme, which becomes very active. And what does this enzyme do? It degrades the extracellular matrix. It destroys the structural integrity of the endometrial stoma. You have now a thin endometrium and a vascular walls which are very permeable, which can always break down and bleed. So what do you do for this? You give them low dose localized vaginal estrogens, which will effectively restore tissue integrity, minimal systemic absorption. That is all that is required, and they do very well with reassurance. Now, how do you manage a polyp? All postmenopausal women with a bleeding polyp has to be removed. Some of them can be high risk. So now we look at this patient. You see, I'm using a scissor to open the internal os, which is, closed. When you use a scissor to open, there is no pain. When you put a dilator, hold the cervix with a vulsulum, there is pain. You see all that sludge coming out, the mucus coming out. And what do you see inside? Look at the endometrium. It is stark, naked endometrium. Nothing is there. But there is a sessile polyp here. I'll show you. You see, this is a sessile polyp here, a localized thickness, and these are larger polyps there. So this is how hysteroscopy helps us. Now, how do we manage endometrial hyperplasia? So we have two types of hyperplasia. One is hyperplasia without atypia. The other one is atypical hyperplasia. Without atypia, medical management is sufficient. With atypia, you have to go for a hysterectomy. Now let me show you one patient for whom I have done a hysteroscopy. And we find, you see, the vessels are there. They are more than normal. You don't expect this in a postmenopausal woman. There are some small areas of calcification. Not looking very dirty, but then somehow I felt this could be an early endometrial malignancy. You look at a tuft of vessels here. But on biopsy, this turned out to be atypical endometrial hyperplasia. So, if there is endometrial hyperplasia without atypia, it is because of prolonged unopposed estrogen exposure. Over 20 years, she has a 5% chance of malignancy, which is very low. They spontaneously regress. That is up to 80% regress without treatment. And what is the primary modality? Conservative and medical. But in an atypical hyperplasia, 8.2% is the annual progression risk. Every year, the cancer risk increases by 8%. And so you have to remove her uterus. So how will you manage a hyperplasia? First, ask her to change her lifestyle. Is it easy? Impossible. Strongly advise weight management, bariatric referral. Well, better said than done, but we do advise every menopausal woman to get into some exercise habit, and many of them do comply. And this could be the reason which they must comply to us to reduce the estrogen overload in the body. So what is the first line medical? The best is an LNG IUS system, which can be left in place for 6 months up to 5 years. Second line, you can give continuous oral progesteron. So I used to use a lot of medroxyprogesterone acetate. Now I have changed over to Dufastan, which is our very own friendly progesterone. Total hysterectomy is not a first line for endometrial hyperplasia. It should be reserved only for failure of medical therapy after 12 months, progression to atypical hyperplasia, or if the patient refuses to follow up. Why is Mirena superior? Because it is very less systemic exposure, high local concentration, very much compliant for the patients. There is no weight gain. There's a 100% response rate with Mirena as compared to 96% with oral therapy. And nowadays, whenever I see a polyp or a hyperplasia, I put in a Mirena. It has given me very good results. And all the patient needs is a bit of a reassurance that don't worry, you'll be all right. And we are there to, remove your uterus as and when it is required. That is all they need. So how do you follow up? You have diagnosed an endometrial hyperplasia. You have put in a Mirena. So if you have done a hysteroscopy and a biopsy and everything is normal, you need to at least do a people biopsy after 6 months. Every 6 months you need to do it. This is mandatory. Many times the patient says endometrium is very thin, but still we recommend that if we can do a people biopsy, it is for the safety of the patient. And if there is a atypia, you have to do a hysterectomy. In the postmenopausal women, we have to do a TLH-BSO. In a premenopausal with atypia, we can just remove the tube and leave the ovary behind. The why? Because in an atypical hyperplasia, there could be concurrent undiagnosed endometrial carcinoma. So we have to do a hysterectomy. Now this is a very early CA endometrium. If you see, now we are just negotiating the os, and we make it as painless as possible. So we try to go along the natural surfaces, keeping the internal os at the 6 o'clock position. And as soon as we make an entry, look at what you see. We have negotiated the os slowly. Still negotiating. Yeah, there it is clear. Keep it at 6 o'clock. Turn it to transverse and enter. And look at what you see. Look at these vessels. Look at these vessels. Absolute neovascularization. 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 Calcifications. Such a tiny lesion. It is an early endometrial malignancy. Now, what will you do if she's a postmenopausal bleeding on hormone replacement therapy? If she's on continuous combined MHT, you have to evaluate if it is more than 4 millimeter. If she is on sequential MHT, you have to evaluate if it is more than 7 millimeters. And what will you do? You have found it benign. Then you switch. If she's on transdermal, you switch to oral, or you adjust the progesterone duration. If she's sequential, you do continuous. If she's on continuous, you do sequential. Best is to insert an LNG IUD, which works most for most patients. Now, this is one of my favorite videos.
नहीं नहीं अभी नहीं अभी करो इंतजार नहीं नहीं कभी नहीं मैं हूँ बेकरार. So the uterus is begging to be left, and the patient and the surgeons, we are scared and we are removing her uterus. So no bekarari, let us not panic, let us plan. There is a reason. There is a reason when we have to do a hysterectomy. When do we escalate to a hysterectomy? If there is a disease progression to atypical hyperplasia,
If 12-month failure, you have given her LNGIUS, you have given her continuous progesterones, but there is no histological regression. If there is a disease relapse, you have given her, she has responded very well, but she comes back with hyperplasia, intolerable bleeding, and surveillance barriers, like patient says, I won't come back for TVS, I will not come back for biopsy. Or if they are not able to tolerate the mandatory histological surveillance. This is the only reason why we have to do a hysterectomy. Thank you very much. And I'm open to discussions. I have finished well before time. I think I have taken about half an hour. And let's get back. What do I do next?
Yeah, Revathy.
Madam, I have to stop screen sharing. Wait, madam. I don't know how to do that. Okay. How do I do this? You are screen sharing. Stop share. Okay. Yes, madam. We are.
You have done excellently. You didn't leave any point.
Oh, thank you.
Every point is covered.
Thank you.
Particularly, everyone's doubt regarding endometrial hyperplasia. I mean, not hyperplasia, the thickness of endometrium during postmenopausal bleeding, when to stop, when to panic, when to plan, and when to leave her. So, overdiagnosis causing psychological, psychosomatic disorders, underdiagnosis missing some malignancy, jeopardizing. So, it is excellently stated. I think the audience who are there are left in no doubt when to intervene. One question I wanted to find out,
Yes, ma'am.
if the woman is on HRT or a combined pills, and if it is sequential, you said it's 7 millimeters. If it
Yes.
is combined, you said more than 4 millimeters.
Yes.
If they come and they say that they are on pills, they're asymptomatic, they came for a routine screening, an educated woman who's, well counseled. If the endometrial thickness is more than 4, what should we do? Should we go by high risk history stratification or clinical exam stratification, or is there any guideline to do tissue biopsy?
Wow, ma'am, you have touched at that gray spot which I never thought about. I would request the seniors in the forum to answer, because if you put it as an asymptomatic postmenopausal bleeding, then 11 millimeter is what requires
Yes.
the pathology. If she is bleeding, then anything more than 4 millimeters, maybe we have to do. Even if she is on a combined, if first 6 months, if she bleeds, we don't have to worry. It's only after 6 months. But this is
Yes.
a very gray area, madam. I think I will require assistance from all of you. What to do? Say if whether we should do a tissue sampling, at least something
Mm.
basic, office hysteroscopy tissue sampling, or
Because there's a patient across your table who is asking, would I get cancer? Should you say no? Should you say you may, or should you assure her? And what about those, follow-ups, the losses, follow-up
yeah,
losses?
madam,
So
if she is on estrogen progesterone, she's well protected.
well protected.
Well protected. If she's on unopposed estrogen, I think my worry would be a little more. I mean, nobody now puts an unopposed estrogen with a uterus intact.
Yeah,
So she will
intact
be on an estrogen progesterone only.
only. Combined one.
A
Combined.
combined one. Yeah, I think perhaps, madam, I will do a tissue biopsy.
I would prefer to do. I was
Yes.
going to tell you the same,
Yes.
because an overdiagnosis in such a clinical situation where
Yes.
there is an endangerment of life or
Yes.
quality of life or morbidity, though no one is dying of endometrial cancer nowadays, but the
Yes.
cost, the future surgeries and visits to the hospitals, cost effective, so many things.
Yes,
All
ma'am.
those things can be avoided if we do a tissue biopsy and
Correct.
counsel them,
Yes.
irrespective of the explanation of using a hormone XYZ. So
Yes,
tissue
ma'am.
biopsy should be a
Yes.
choice, a
Yes.
ready choice for
Yes.
clinicians, not to miss the diagnosis, but it may cause a little some over
Yes, but still it is comfortable. Office hysteroscopy
worthwhile.
is comfortable and very
Worthwhile.
much possible, and
Yes.
comfortable because we can allay a lot of our fears, and we
Yes.
We ourselves see the endometrium.
Yes,
Many times I tell her, local Andy, there is nothing there, you don't worry. And we put in an LNG IUS and leave it alone. So she is
exactly. Yes,
protected.
yes. Very correct. Very correct.
Thank you. That
So
was a
that one
wonderful point.
small tissue biopsy will prevent so much of distress for the doctor and the patient, I
Yes,
think.
ma'am. Absolutely, ma'am. Yes. Thank you.
May
Thank you
we
for
ask
that
for
point.
all the seniors
Yes.
who are there?
Dr. Chellappan Karupaya, sir, thank you very much. I have seen the, sir, it is actually, it should be a routine management, sir. And office hysteroscopy is now gaining a lot of ground, and
Yes.
each one of us must attempt to learn it. There are problems. The challenge is if I say 25,000 for an office hysteroscopy biopsy and
Mhm.
Mirena, then they say, Madam, insurance తీసుకుంటాను, madam. It may cost
Yeah.
3 times the
Yeah.
money. But they still want it in insurance. So insurance lo admit చేసుకుంటే automatically it
Yes.
goes off under anesthesia. So
Yeah.
office hysteroscopy, they don't want to shell down. Even 10, 12,000, they don't want to shell down. So
Yes.
those are the challenges for us to, what I do is I do office hysteroscopy for some of them in the OT only. I tell them everybody is around. Anesthetist is
Mhm.
in the background. If you want, I will
Yeah.
give you anesthesia. Otherwise, you can go home. So office hysteroscopy is something which we have to, strive to pick up. If not an office, at least hysteroscopy operative should be our primary approach rather than do a DNC and a hysterectomy. That is something which we must work. Hi, Samira. Thank you.
Mhm.
Thank you for being there.
Hello, Samira.
My question, what is the local estrogen usually you use in case of atrophic vaginitis? What
Yeah.
is the thing you are using?
Madam, for me, over years, I am very happy with estriol because it just
Estriol.
doesn't enter the endometrium. But there are, the late menopausal women for whom I feel estriol may not work.
May
And
not
we
work.
can give them Primarin or proper estrogen creams also. So, very rarely I've had to use, but I think we may have to start using for the later ones because estriol may not work for those intensely atrophic patients.
So, Primarin cream. Then.
Yes, yes. Remember. Basically, we can start off with Evelon. And
Yes.
I recommend it for every early postmenopausal. We don't want her to land up in GUSM. So as soon
Yeah.
as they come, I say start using Evelon. Whether you have complaints or not, from now on you start using so that she won't come to me back with an atrophy which I cannot handle.
So,
Just today I got a patient from the
Okay.
US. She has gone there, come here, and she's my old patient. So I told her that she has only GUSM, dyspareunia, pain, unable. So then I told her you have a wonderful drug called ospemifene, which is there in the US and we do not have it. I cannot
Mhm.
prescribe you that. All I can give you is an estriol cream. Go back and take ospemifene from your doctors there. So
Yeah.
that helps so much in atrophic vaginitis.
so
Madam, why
they
do you
had
prefer?
just bilateral salpingectomy along with hysterectomy. Ovaries function for some time. When shall we advocate these estrogen creams?
Yeah, madam, if the ovaries you think are functioning, like normally she will come with vasomotor symptoms. They come with complaints when the ovaries start
So
failing.
at that point, we should take a call
I think I
for
would
the
maybe
GUS.
even doing a perspiculum and seeing how the vagina is. So I would take a call. Yeah, if she started going, see this today's patient said I had VMS. I settled down. There is no VMS now. She's left with GUSM. So I think Evelon is very harmless, and we can be a little
Mhm.
early in advocating Evelon. Is what I.
Even with ovaries in situ, we can advise.
Yeah, I mean, if
Maybe
it is 5 years post
three,
hysterectomy.
3 years, 5 years. Yeah.
5 years post hysterectomy,
So
mostly.
interrupted therapies.
Yes, yes,
Mm.
yes, yes.
Madam,
Thank
regarding
you
this
so much.
histriol, why do you prefer histriol over Evalon? I mean, you mentioned
Both are
initially
good.
Evelon is histriol, sir.
Both are good.
And
estradiol, no?
no.
Huh?
Estradiol is different. Evelon is histriol, which is the
Okay,
safest cream because there is no systemic absorption. So
okay.
early in my career, I have seen women on Primarin cream or estradiol cream. I'm not getting the name of it, but the
Histogel, I think.
estrogen.
Estrogel.
These creams, I have had a patient come to me with postmenopausal bleeding and endometrial hyperplasia.
Okay.
So
Yes.
I feel why to add up to a problem when there is no problem. If estriol can do the job, it is great. Only in a very, very badly atrophic patient, I would like to, add a Primarin cream or an estradiol cream. Good, definitely they do good, even if it is very, very less. over a period of time, they can cause endometrial hyperplasia. So surveillance is required for them. But if you use a histriol eval, surveillance also is really not required.
Okay. One more thing I liked about your presentation was about that asymptomatic women, the cutoff being 11.
Yes.
Recently, we had a very bad experience. One young lady, our relative from Hong Kong, landed up in Mumbai. She had just gone for a regular checkup in one of those very posh hospitals. And in the TVS, they found 11 endometrium. She was asymptomatic, gone for a regular medical health annual checkup only. And she had come after 5 years, so we had only suggested. And what happened? Because it was 11 the doctors there panicked. And she basically went for hypertension and diabetes and thyroid screening, but she ended up in the gynec OPD.
Yes.
There they panicked, say, oh, 11 she needs a hysteroscopy. Now, she was a nulliparous lady and 59 years and well into menopause since 9 years. But she said, I mean, asymptomatic, but they insisted that they do a hysteroscopy. They failed in the hysteroscopy. Then they suggested that, oh, we couldn't enter your os. They did it under anesthesia. So now you will have to go for an MRI and we will do a hysterectomy. So I had to put my foot down. I said, I sent her the references, the recent ACOG reference,
Yeah.
no?
Yeah.
And fortunately, you also highlighted and that this madam. Then we have various groups. I had just put up this case, and you will not believe 90% of the gynecologists wanted to do a DNC biopsy or a hysteroscopy biopsy. So this concept of no 4 and especially the 11 for asymptomatic
No,
women
but the 11
that
is
has
a
to be
border.
stressed.
So she's at a border of 11
Yeah,
So it's
but then
like
it's a
it is
poor
not less
slope.
than, so doing a hysteroscopy biopsy is not a bad thing, I would say, for 11 Maybe if she was 8, 9, 10. Now, supposing somebody comes with a 4 millimeter, okay, I would say maybe wait a little bit in a bleeding. So
So what is
asymptomatic,
your suggestion that even if she is asymptomatic with a 11 10.8 to be precise, it
10.8,
was
we
10.
can wait and watch, sir. I mean, if you go strictly, and even this endometrial thickness is based on the transvaginal ultrasound. The
Yeah, yeah,
MRI
yeah.
could give a totally different reading. All these protocols are based on the transvaginal ultrasound. So
Okay,
perhaps feel that okay, a 11 endometrium with a nullipara could be watched, but she's at the border.
okay. No,
She's not
that's
at the
right.
safe
But
zone.
is it
She's at the
is it
border.
would it be warrant an emergency? I mean, sort of DNC hysteroscopy, DNC, or an MRI and a hysterectomy. Would such a case warrant? Because she just walked in for an annual health checkup.
Annual health checkup, yeah.
Yeah, pap
She,
smear was.
she doesn't need a hysterectomy, but she definitely needs a tissue biopsy
Tissue
because
biopsy.
she is on the high risk group being
Yes,
a
yes.
nulliparous
No,
woman.
I do
With
wouldn't a
agree.
9 months,
wouldn't a pipel suffice in
yes,
such case?
So if a pipel works, see,
Hmm.
a pipel will not see the 11 millimeter could be a polyp that she is harboring.
Yeah, yeah, yeah.
You need a very good hysteroscopist. Like we have 2.9 scopes, we have 1.9 scopes.
1.9
Yeah,
also,
and
yeah.
in a nullipara with an atrophy, it can be technically challenging to do a hysteroscopy. So
yes,
a very, one of the good hysteroscopists can
Mhm.
definitely have a
can
look
do,
inside the uterus. It's not
can
so
do.
difficult. Yes. People
But
may fail.
in this
Pipel.
case, hysteroscopy is
Yes,
recommended
yes, sir.
for a 59-year-old woman nulliparous with 11 millimeters
Yes,
of endometrial thickness.
yes,
With the present day guidelines, it is
Hmm.
better we do hysteroscopy.
yes,
Of course, the technical problems apart,
yes,
the indication is there, but the
yes,
technical problem because she's nulliparous, because also it's very narrow. So, like Dr. Revathy said, very narrow scopes, etc., can be passed, and an expert in hysteroscopy can still do it,
yes,
and
yes.
it sort of keeps the patient and the doctor a
Yeah,
little
safe,
safe.
right.
Yes, yes,
But
yes.
then what if okay, it was attempted, it failed, but wouldn't it be prudent that we put her on a proper transvaginal screening and with color Doppler, and then just keep a watch on it, and then maybe do it again if things are not, I mean, going on the wrong side. Or is it a case for
You wouldn't even
rushing
know
into
if
a
it is.
hysterectomy?
So fair enough. So you're talking of a border. Supposing we got a 12, there is no doubt. This is a cat on the fence. It can turn this side, it can turn that
Yeah.
side.
And
So,
moreover, I mean, what about asking her to come for follow-up, regular follow-up with a TVS and all those days when she is due to come for follow-up? What about her psychological quality of life?
yes, yes.
Whether I turn into malignancy,
Oh,
whether I
no,
will
no,
become
no, no,
malignant
no,
next
no,
time.
yeah, I got your point. My point is, should we strictly stick to the 11 protocol for these women, or we then again we start doing all this, our mental adjustments and take her for
True. Actually,
by
as protocols go, 11 is the cutoff. So you're justified to wait a while.
wait a minute.
As
That is what
protocols
I
go.
feel
Wait
because
a while for some symptoms. If she
uh,
bleeds, then again it
I
becomes a whole
warn her
millimeter
because she's
protocol.
a highly
Yes.
placed, educated lady, executive,
Yeah.
and
Yeah, then
she would
we
be.
could wait. Yeah. But she should know that she's right at the border.
Exactly,
Yes,
exactly. Yes,
yes.
yes.
Yeah.
So,
Thank you so much for the
And she
insight.
should come for
Also,
follow-up. It depends. It is individual discretion whether the patient is educated,
Yes.
understood your
Correct.
counseling, whether she can
yeah,
come for
yeah.
follow-up,
Yes.
and
Yes.
that she has understood the importance of next TVS, the
Yes.
thickness,
Mm.
etc. That she is on the border.
Yes.
I mean,
Yes.
Mm.
let us
Correct.
not miss a case or miss a follow-up and
Absolutely.
Yeah,
give
yeah.
her
We
false
should not
assurance.
miss the boat. We
Yes.
should not miss the
Should
boat.
not.
But
Yes.
Miss the
it's
boat.
the proper counseling and monitoring should suffice for this
Mm.
lady
Yes.
and
Yes.
keep her.
Perhaps. Perhaps. Yes. Thank you
also,
very much.
apart from
Yeah.
thickness, we are now speaking about the homogeneity, the vascularity. So
Yes.
Doppler also matters.
Yes.
Doppler
And
Yes.
matters.
Doppler also matters. We are not
subendometrial
just
zone
sticking
also.
on to
Yeah,
the thickness.
Yes. Yes.
yeah. Mm.
Yes, yes. There are a few questions here about estriol dosage, intravaginal application. Yes, normally that again has a dosage in which you give about 1 milligram intravaginal application daily for the first 15 days and then twice weekly for 3 months. In a little elderly person, it is recommended to give even longer. But what I follow is a 3 month routine of which the first 15 days is every day and then we give it twice weekly. This is to address Geeta and Dr. Deepthi. These are the two questions. Again, Evalon is something if we could use it earlier on rather than waiting for it to actually go into a GUSM pattern.
Mm.
Any other
Any more questions anyway in the chat box?
anyone who does not agree with me and feel that it is not correct? Anyone who would like to, differ with whatever we have discussed?
Madam, where did you take this office hysteroscopy training? I am curious about that.
Yes. Sir, actually, Stephen Petocci, sir, is one who has actually advocated this, and
Yeah.
there are many in India. There is Dr. Milind Telang at Pune, then there is Dr. Haresh Waghela at Mumbai.
Dr.
So
Revathy, you
in
are one
Hyderabad,
of
two
the
or three of us are
IIT
doing, or maybe
trainer,
Metro
no?
doing.
You are Eagle
Yes,
trainer,
madam.
no? You
I'm not
yourself can
IAG
train us.
trained. I'm IAG member. Sure, madam. Why not?
You can
Off
train
is
us.
hysteroscopy. Yeah, why not, madam? Why not, madam? Let us share and learn and, ultimately the woman who comes in front of us has to be benefited. Each of us are catering to a small
Yes.
locality of patients. It is not that anybody is better, anybody is worse. Hardly matters. The 20 patients who come to us, we can do our best for her. So learning is always, it is
There.
wonderful. However much we can learn, let us learn. That's one thing.
The learning curve never comes down. It
Never
goes
comes
up
down.
and up.
Yeah. And there's something new baby on the block.
Always.
So
Always.
yes, right. So
So very nice presentation. If anyone has any other questions, let's go for the question.
yeah, I think I can't see any more in the chat box.
Madam, after doing this biopsy, nowadays these endometrial cancer people are talking of a lot of IHC markers and all that. Does it fall in the purview of us gynecologists to add any other further IHC marker, or we just suffice with this histopathology examination only?
I think they do demand for IHC markers, sir.
Yes,
And
of late,
if
many
you
are
ask about
asking
our
for,
purview, yeah,
yes, many are asking
markers.
for yes, histochemical reactions, but
So we are still learning.
immunohistologies,
Yes.
there are immunohistologies
Yeah.
which will prescribe their treatments. They
Yeah.
are for treatment protocols.
Yeah. For the
So I
prognosis
think for prognosis and treatment
and treatment.
for
Yes.
them.
Mm.
So I think in our purview, since we are very busy, diagnosing a malignancy and taking oncologist's opinion
Correct.
for the type 1, type 2, up to type 2 hysterectomies, probably that should suffice for us. But
Yes.
later ones and the accurate diagnosis, whether it is anaplastic or, differentiated, the varieties in the malignancy which may influence the treatment modalities, the oncologist is more concerned. So they always ask for immunohistochemistry
Yeah. So
question.
since we have done the biopsy, I
Yeah.
think there is a responsibility on us. Normally, the pathologist herself will say, "Why don't you get a P53 or
Yes.
something?" So then, if they
Yeah.
then I coordinate with the medical oncologist, would you like it? If he says yes, I think we have to get it done. And
We have to get it done.
this again is an area of learning because we belong to the
Yes.
old generation. We don't know
Yes.
much about this molecular marker. We better start
Yes.
learning. Perhaps we'll be able
Yes.
to use it for the benefit of the patient.
Pathology
And
suggests
and
detailed.
also liaise with the oncologist from this point onwards, so
Yes.
that it will be a twosome who may do justice better
Yes.
than
Yes.
a single one.
Yes. Yes. Yes.
Madam, one more question. You mentioned about type 2 endometrial cancer, where the endometrial thickness is less than 3 mm. So, if we extrapolate the postmenopausal bleeding evaluation, then that means irrespective of the endometrial thickness,
Yes.
we will have to do a tissue biopsy for each and every postmenopausal bleeding, because there could be a hiding type 2 endometrial cancer also.
Correct. So what as per the protocols that I have read, when she first comes to you, you have evaluated, you have found it less. If you don't want a loss to follow up, just do a PPL or an office hysteroscopy. You have ruled out everything, you have sent her. But again, she comes with recurrent episodes of postmenopausal bleeding. Then even a reassuring 3 millimeter endometrium is not enough. You have to do a hysteroscopy. So there are typical indication is one is that if she comes with recurrent postmenopausal bleeding. So even if you have evaluated her totally in the first and then sent her and again she comes for a recurrent postmenopausal bleeding, we have to know that endometrial thickness on ultrasound alone is not enough. And we have to subject her to a hysteroscopy. So I did some study on this type 2 cancers also. Hysteroscopy can locate. It is not that you can't locate by hysteroscopy. You have to do MRI, you have to do a hysterectomy. No. I did a lot of reading, and what I understood is there will be some lesion in the endometrium which you have to biopsy. Now, the biopsy again is a trick. When you have such a thin lesion, you cannot use a scissor, you cannot use a forceps, you may have to use a very fine resection, take out that area, send it for a biopsy. So that way we can rule out a type 2 cancers. So that's something which we need to be aware that we should not skip a persistent bleeding. We should not skip. That's all.
And one of the serious misunderstandings with our own colleagues is they some even senior doctors, when we do this hysteroscopy in this postmenopausal bleeding, they say, oh, you are putting fluid under pressure, you are translocating the cancerous cells into the peritoneal cavity and converting a low grade lesion into a high grade one.
There are enough and more studies to disprove that. But all said and done, we need to use very low pressure, sir.
Low pressure.
So in an office hysteroscopy, we will keep it as about maybe if you can see it in 70, maximum 80. Even in operative hysteroscopy, when we start off, we use only 70, 80 and try to visualize. The moment you see cancer, then you stop short. You don't want to do a resection. You don't want to, put in a resectoscope. You try to, preferably take a simpler biopsy. Yes, we are aware of it, but then most of the studies have disproved that a hysteroscope will convert a stage 1A into a 1C. It is disproved, sir.
Yeah, good evening, Dr. Revathy. I just joined little late.
Hi, Dr. Leela. Hello. Wonderful to see you. Yeah, please
Yeah,
give
I'm
your...
listening to all your discussions. And Dr. Chellapan, I think this is what you have been asking. It's only a theoretical possibility because I have done a lot of hysteroscopies and diagnosed endometrial cancers, but none of our patients, out of interest, even we collected the peritoneal washings or
Wonderful.
fluid, but none of those were positive.
Yes.
So many people have that objection, but of late, I strongly believe in doing hysteroscopy, especially for postmenopausal bleeding for various reasons.
Yes.
And actually, Dr. Revathy also has nicely said, even thin endometrium recurrent bleeds, yes, especially thin individuals and other things, we definitely need to do hysteroscopy. It gives a lot of information. And
Yes.
sometimes even benign lesions, we can take it out completely.
Yes.
And then the woman doesn't need further hysterectomy. So you are saving the uterus. Even
Yes.
if the hysteroscopy is normal and somebody comes with recurrent postmenopausal bleeds, yes, there is an indication to do hysterectomy.
Yes.
But one has to evaluate the cavity properly. That's what I feel.
Yes. Yes.
And regarding asymptomatic endometrial thickness, I think the age matters. Basically, it is with regards to the postmenopausal women. Premenopausal, we have to make sure with the menstrual dating what is the thickness of the endometrium.
Yeah,
But
this is only
postmenopausal,
postmenopausal,
yes,
madam. This
postmenopausal asymptomatic thickness of the endometrium, yes, sometimes uh, even on a regular follow-up, if there is a persistent, no change or slightly increasing endometrial thickness, yes, we are doing hysteroscopies. At least I am doing hysteroscopies. I have removed a lot of polyps also, which are all benign. So
Yes.
it gives us a lot of reassurance to the clinician as well as to the women. So I strongly, for some reasons, probably from last 20 years, I've been practicing hysteroscopy, and I find it a very, very useful diagnostic as well as therapeutic tool.
Yes. Thank you. Thank you, Leela ma'am, for your inputs. They're very nice. And I think Sandhya ma'am, you have to thank me, no, madam. I finished the presentation in 25 minutes. We had so much of interactions today. A lot of
I'm waiting for everyone to interact and ask you questions so that all doubts will be dispelled today
Yes.
regarding PMD.
Yes, ma'am. Yes, ma'am. Yes.
Okay. If anyone else still wants to,
Yeah, there is a question from Dr. Archana. How long do you give HRT in postmenopausal women? Sandhya ma'am, would you like to answer that question?
see in postmenopausal
Women,
woman,
how
the
long do you give
indication,
HRT?
yeah,
That's all. How
the
long?
indication, it depends upon the indication, one indication, two, when the indication is subsided. For example, if we are giving for BMS or GUS, it should be a strong indication. And once we give it for that indication, once the symptoms are subsided, she can stop and she can start again to a maximum of up to 10 years from last FMP or to a maximum of 60 years. But she can stop after some time. See, the idea is smallest dosage and most effective dosage for the smallest duration. It is a symptomatic treatment. It is not a treatment, complete radical treatment. An estrogen supplementation is a symptomatic treatment to improve the quality of life.
Correct.
And of course, so many other things follow with the quality. Once her symptoms have subsided, it is 2 months, 6 months, 8 months, she can use. Up to a maximum of 1 year also she can use. And once her symptoms have subsided, we should stop it gradually, tailor it up and tailor it down. Again, if necessary, in the same woman, for the same complaint which comes again or some other complaint, we can start.
Thank you. Thank you, ma'am. Dr. Archana, there are experts like Sandhya ma'am and many more. I hope you are a part of the Menopause Society. If not, please become a member.
Yeah. Did her question is answered or not?
Dr. Archana, are you happy with the answer? Yes, ma'am, she's quite happy. Now, Dr. Mamta says asymptomatic endometrial thickness less than 11 millimeter. Actually, yes, there is no need to intervene, Dr. Mamta. We have all been having that 4 millimeter, 4 millimeter. Anybody about 4 millimeter, we have to put in a scope. Protocol says up to 11 millimeters. You don't have to intervene. Okay. But yes, well, it depends. We don't have to. By protocol, we don't have to, unless she bleeds. Dr. Deepthi, yes, thank you. Dr. Deepthi, regarding HRT treatment, what is for hot flushes? Yes, Dr. Deepthi, I think Dr. Sandhya just answered that to improve the quality of life, if she is really, miserable with vasomotor symptoms, there is an indication for starting HRT, and it is, yeah, there is a lot of considerations, pros and cons, how you start, when you start, how long you give. But we have something wonderful for women who are menopausal. So we have, yes, we do give.
I should rephrase the answer. When
Yes.
there is an indication and when there is no contraindication.
Absolutely. Yes, madam. Yes, madam. Yes, yes.
I know. So I think I have
Madam,
to
if
thank
she is,
you.
madam,
Yeah.
if she's comfortable, we go up to, as you said already, she can go, if she's very happy on hormones, the bone protective action, all those things, we can go until the age of 60 years or 10 years
60
from the
years.
post-menopause.
Yeah.
Yes,
Yes.
she can.
Okay.
Dr. Archana, your questions are totally HRT questions, combinations. Please attend more lectures. We will cover up all this. This is totally restricted to postmenopausal bleeding. So I love your interest, but kindly join our society. There are 100 and more lectures which keep coming up.
Uh, Thank you, Revathy. Thank you so much. It was wonderful and very, very informative. And, looking at the interaction and the interest that you have evoked in such august audience, I think it is worth the time.
Madam, I love you, Sandhya ma'am. Believe me, you're one of the nicest people around. And my personal thanks to you for
I am
being so kind.
flattered.
Yes, honestly, madam, that I truly believe in it. Thank you. And I
And
Thank you so
I
much, Dr.
should,
Rev.
and I should thank all the audience and all the seniors and the faculty heads who have attended,
yes,
showing interest in PMB. It means that people are getting interest in the women,
yes,
in the midlife women, and in the welfare of the midlife women. I'm very, very happy. And this is an appeal to all the audience who are already members to become more, to make more members,
yes,
and
yes,
those who are not to become the members and increase it. Please, each one catch one, make a member.
yes,
And
yes.
this is my appeal to all the audience.
I
You have
think,
to, you can listen to Revathy more
yes.
and more.
We can listen to stalwarts. I am just a baby here. Dr. Prasuna, one question I will take. 11 months post hysterectomy, minimal vaginal bleeding since 1 month, vault is healthy, no coital injuries. If you have excluded all the other reasons, you can give her, it could be most likely atrophic vaginitis. You could give her Evelon. Local estriol cream will definitely help. And Sandhya ma'am, Payal ma'am, thank you so much. And who is the, I keep forgetting, the apna, ye ClearNet ka person, who is the person today?
Anushka,
Anushka, thank you for your silent presence. I would like to tell one small thanks to my daughter, madam, because all these, these technicalities of putting all these things, sometimes it beats me, and she's there to help me out, share screen, ye karo,
I
ye
should
karo.
thank your daughter
Thank
myself. HMS thanks your daughter too for helping the digital part of it.
Yes, madam.
And
Yes,
the digital part also was very good because it was eye-catching and evoked interest in continuing to
thank you.
watch.
Thank you. Wonderful.
Thank you all.
Yeah,
Thank you, Revathy.
thank you very much, ma'am. Yes. So
Bye-bye.
we end today's session, then we all
Yeah.
leave. Thank you. Thank you
Shall
very
we
much.
end? Anushka? Is she here? Clarinet?
I don't know.
Mm. She
Anushka,
must
ClearNet, I think, I
be
don't know.
listening.
Can we just leave the
Yeah,
meeting, madam?
we
Right.
can leave the
Yeah.
meeting.
Thank you.
Yes,
Thank
we
you
can
once
leave
more
the
for your
meeting.
presence, ma'am.
Thank you
Thank
all.
you very much. Yeah. Thank you.
Thank you all. Bye-bye.
Hello? Hello? Thank you, everyone. Thank you very much for giving us the opportunity to host the session. Thank you very much. So, with this, we will conclude today's session here.